The last member of our panel is Dr. Patrick Fox, who is a psychiatrist and has been on the front line in Connecticut working as a clinician and then director of the Whiting Forensic Division, which is Connecticut's maximum security hospital, and now is acting director for the Office of Behavioral Health for all of Colorado.
Good afternoon, and thank you for the invitation to present here before the National Academies. It was an honor and a privilege, though it made me a little bit nervous when the invitation was extended. And then I learned that I had 15 minutes to talk about behavioral health care in the correctional system, and that actually terrified me because it's a discussion that is very robust and that we could spend a great deal of time on. But I want to hit some of the salient highlights. And I use the term transinstitutionalization to really talk about that population shift, cost shift, burden shift from the mental health systems that are community-based and state hospital-based into the correctional system. And the correctional system is essentially a booming business. As we'll see, the red line represents the number of individuals who are incarcerated, and we see a significant increase beginning in the mid to late 70s and further increasing. In the most recent years, since about 2009, this population has remained relatively stable. Relatively stable, though, is a relative term. There's about 2.5 million individuals who are presently incarcerated. And if we include incarceration, parole, or probation, there's 6.7 million individuals. That represents 2.9% of the population, or 1 in every 35 individuals in the United States, is in some way subject to correctional management. Equally importantly, if we look at the population of persons with behavioral health disorders, 40% report, there's a 40% lifetime prevalence that they will at some point become incarcerated. So there is a portal of entry that we need to attend to. But these numbers in and of themselves don't tell the entire picture. There are huge racial disparities, and I wrote "and justice for all" and it's injustice for some, that certain portions of the population, blacks and Hispanics, are substantially overrepresented. The larger maroon graph you see is for males, and then the smaller blue graph that you see here represents females within the, it's not going to aim over there, within the incarceral population. This is different than the natural distribution of race within our society, and lo and behold, it's also trending with respect to substance use arrests. As had already been reported, the vast majority of individuals who are entering into the criminal justice system in total, and the population of persons with behavioral health disorders, aren't being arrested for violent crimes. We have a commensurate and concurrent increase in the number of arrests for substance use and substance possession. And when looked at by racial demographics, the majority of users are essentially not representing the majority of those individuals who are getting arrested. And we know about stop and frisk laws in New York and the attention that that's drawn. But again, this is a striking statistic that I think we as a society really need to begin to address, because these disparities perpetuate throughout the entire criminal justice intersect, from those who are placed on death row to those who are found not guilty by reason of insanity, where Caucasians are overrepresented or have a better chance of being found not guilty by reason of insanity, and even for probation and parole decisions, that these racial disparities carry themselves throughout. The persons with behavioral health disorders are also essentially overrepresented, and as Madeline had previously shown, this movement of transinstitutionalization, while not solely accounted for, and a direct relationship with closure of hospital beds to a concurrent increase in correctional population, it doesn't account for all of it, but that is a substantial shift that we're currently seeing. For individuals that are within the correctional system, there are high rates of psychiatric disability. we see in state prisons over half, and essentially over half, with a more significant pooling of population even within local jails and prisons. Within local jails. And this is basically then bearing on a significant increase in cost. Eric Kane had mentioned yesterday that with deinstitutionalization, there was a reduction in cost at state mental health hospitals, and the expectant then shift of funds to community mental health services that did not occur. Well, as this population migrates from the community that's not well serving them into the criminal justice population, we're seeing an increase in cost, but it's not keeping pace with the burden that the population is inflicting. And I don't mean this slide as well to imply that all of that increase in cost is solely related to mental health care. It's also medical costs as well. Here is a breakdown of the states. 42 of the 44 that reported showed significant increases over the prior 7 years, 52% increase in healthcare related costs. Now, some of that is related to baby boomers who are incarcerated, who are having more onset of later life medical complications, but that even does not represent the bulk of this. The bulk is in provision of mental health services. And why also is this important? It's because the population is not being served in an environment. Couldn't think of a worse environment to have a person with a psychiatric disability trying to have their psychiatric disorder managed in. We think about psychiatric hospitals. The primary focus and mission is the restoration of health and the treatment of a malady, whereas in corrections, it's really confinement. It's a punitive environment. 90% of the staff at a state psychiatric hospital are mental health professionals or playing a supportive role to that goal. Security is sort of an ancillary service that has a presence, but isn't that great. Step into a jail or prison, 90% of the individuals are correctional officers. They're wearing the uniform, they've got the taser, they've got the mace, they've got the cuffs. And the therapeutic population within that represents a small minority. So it has a significant impact on that person's perception of the environment in which they are. And that while not absolute, within the prison system, when there's a behavioral health emergency, the first responders on the scene are those correctional officers, in part because they outnumber the therapeutic staff, but also it's essentially the way in which the culture grows up. Whereas in most psychiatric hospitals, when there's a behavioral health crisis, it's the professional mental health staff that are the ones who are actually running the behavioral health emergency, and only in situations where the level of threat exceeds their capacity to safely manage, do they then transfer control of that situation to correctional officers. So it tends to be with greater understanding of trauma-informed care and the recovery movement, a verbal and a softer approach if you're in a psychiatric hospital and having a behavioral health emergency. And I'll show you a picture later of a gentleman in a jail who's having a behavioral health crisis and the response within a correctional setting. And that the Joint Commission and CMS serve as accrediting bodies and commissioning bodies for hospitals, whereas the American Correctional Association and National Commission for Correctional Health Care work on the correctional side. Very different standards and expectations. But lest you think that it's all bleak, whereas most in the community may struggle for treatment, those who are incarcerated have a constitutional right to treatment. And this slide is sort of an attempt at humor to describe the fact that if your access to healthcare is limited by high fence and barbed wire, then the state has a duty to provide you with those services that you otherwise could receive were you not incarcerated. And in the interest of time, I won't go into too much detail, but just to understand that within the last 30 years, there's really been an improvement in the quality of behavioral health care in prisons compared to how they had been prior to that. Some of that is borne by case law. In particular, it was Ruiz v. Estelle, and then later Madrid versus Gomez, where the expectation was that inmates would be screened for the presence of a mental health disorder, that they'd actually be treated, and this was from Ruiz, they'd actually be treated, and that seclusion and close observation did not solely constitute treatment, which it had prior to that. That there will actually be a medical record, and that it's different than the custody record, and that it would be basically confidential, and that suicide prevention would be an integral part of that person's expectation when they enter that facility. And then lastly, that psychotropic medications, if used, there would be safeguards around them so that they weren't used indiscriminately. And again, if time permits, I'll talk about that briefly. Americans with Disability, the Prison Rape Elimination Act, as well as other state and federal regulations, have since helped to improve the quality of care. And briefly, these are the entities. The first two are voluntary. The US DOJ, in compliance with their correctional standards, is not voluntary. And as an aside, the National Commission on Correctional Health Care really arose out of the American Medical Association and basically broke off from that. And so its origins really emanate from a medical profession, whereas the American Correctional Association, as it shows, has been around for nearly 150 years. It provides accreditation standards for about 90% of the jails and prisons in this country, and sets global standards. So it has to do with not just delivery of health care, but all other aspects of correctional administrative functions. The correctional mental health care, as a result of all these, has improved. So this is looking through the Bureau of Justice Statistics, mental health treatment and what's provided across the country. And you'll see that the vast majority of individuals, despite the fact that there was a court case that said that appropriate screening should occur in all instances, well, 95% compliance with that, which isn't too bad. You'll see the provision of psychiatric care available 24 hours a day occurs in the majority, but not a comfortable number of circumstances across the country. It's important to remember as well, we talk about jails, we talk about prisons, they're set up very differently. As Dr. Greenberg explained, that jails take care of individuals who are pre-adjudication or who are serving, in general, a sentence of less than a year. Prisons manage individuals who have been sentenced, who have lengths of prison or sentencing terms of greater than a year. That the funding sources for jails are derived generally from county funds and sometimes with a little bit of state funds kicked in, whereas the state prisons generally come from state funds. And so even within a state, there can be wide-ranging variability in the quality of mental health care that can be provided at that jail, because the county's tax base and the burden that it can bear to provide those services can be more constrained. And this is, for those who haven't been in one or seen one, this is what a typical county jail can look like. Some of them have improved, maybe a little bit better paint. But you can understand why having someone spend an inordinate period of time with a serious and persistent mental illness in an environment such as this can be less than therapeutic and helpful for them. There is treatment that's available, but again, significant variability. A lot of that depends on the funding source and the streams through which a community decides to allocate funding. And in some areas, these counties are having to decide whether or not to devote money toward their jail or their school system. And we know that if there's a ballot that goes before the populace, the school system will generally win. If you basically say jails and then further clarify mental health or medical treatment for individuals in jails, as opposed to we want to build more jails to hold more people, there's even greater resistance in many communities because people feel that they're still adopting a non-therapeutic jurisprudential model, that these are individuals who've done something wrong and that they should be punished. And we're running low on time. There we go. I'm just going to talk very briefly that the goals of treatment in those correctional settings had historically been just to avoid bad outcomes, and that over time, what we're actually seeing is the development of independent living skills and social skills. Therapy now that's beginning to address, as a result of this reform, some of the needs that individuals have. So both the treatment specifically, as well as any of those other general determinants. So vocational training to give them skills acquisition, social skills training to help them to get that job that, for which they'll apply. And then I'll briefly skip over that in the interest of time, but just to provide you a picture, even in maximum security correctional environments, group therapy can occur. It occurs under these sorts of circumstances to ensure that, that individuals won't harm one another. But these are some of the lengths to which correctional facilities will go to ensure that, and you can imagine how therapeutic a milieu is this, right? Sort of, I see you through the bars. But these are some of what we'll encounter in working in correctional settings. Running short on time, want to talk briefly about medication use. Prior to the 1990s, in correctional facilities, medication administration was often used for improved management of facilities, very much like what we saw in state hospitals. So you want to give tranquilizers to help keep people calm so that they're less likely to be violent. Since the 1990s and the Ruiz case, the medications need to be much more narrowly tailored. Medications can't be used indiscriminately. It's important for people also to know, though, that there is a black market for certain medications that can be ground and used as a substance of abuse. And so there are now tighter controls on the way in which medications are administered. Another challenge, though, particularly in jails, has to do with essentially churn. That we talk about it with respect to the Affordable Care Act and whether people are going to have coverage, but understand that an individual may be treated in a community mental health center, and then they get arrested. They end up in a county jail. That county jail then needs to try and reach out to the community mental health center to find out what medications and what treatment that person had received when they last received it. That person gets arraigned the following day. They get discharged. And so before treatment can even be effected, they get discharged, and there may or may not be adequate aftercare follow-up. The disposition of the individual, as opposed to in a typical psychiatric setting, is bound by the constructs of the legal system rather than that the person's therapeutically improved. There are instances in which, certainly if civil commitment criteria are met for that state, you can civilly commit that person, but it's often difficult to get individuals admitted on that short notice. Talk about suicide. Suicide in jails and prisons, we hear a lot about it. It's the second leading cause of death in jails, third leading cause of death in prisons. Individuals are 3 times more likely to complete suicide in jail, and half of those completed suicides occur within the first week of incarceration. So it's important that that screening and assessment for suicide occur. The majority of them occur as well in a disproportionate number in lockup, even within the first 24 hours. Persons arrested by police, they may not have space at the jail yet to bring them, so they're held in the police department pending transfer and referral. But you see this significant decline in rates. A lot of that has to do with the improved standards and requirements that have been implemented. This is what it often looks like in a correctional facility or jail with better resources. This is a floor flush cell. There are no fixtures. The person is wearing a suicide-resistant smock, and there's a camera in that cell. So close monitoring. They manage for withdrawal. We see a significant increase in suicidality as a person's withdrawing from substances. And it's also important to help the facility staff to understand that there may be certain interventions that can be affected that will reduce that person's potential for suicide that they can do. So if the person's asking for a call to a family member or trying to resolve another issue to make sure that their child is well taken care of because their arrest was unexpected, enabling them to make those calls to make sure that their affairs in order can significantly reduce distress and help to reduce the potential for suicide. It's also important to be aware of when their court date is scheduled, if it's if it's a high-level charge, so that you can basically take proactive steps to move them to a different area of the correctional facility where they'll have closer monitoring, and to ensure that if they get bad news in court at sentencing, or if they're heading into court, that's often a time where we see a significant spike in suicide attempts and completed suicides. ADSEG, it's all in the news now. You probably saw last week in the New York Times, New York State has banned administrative segregation for certain populations and put restrictions on the length of ADSEG. Colorado has done essentially the same. This is a 23-hour-a-day lockdown, diminished contact with other human beings. There's limited access to your own personal belongings. It's a real dehumanizing environment, and the effects on healthy subjects, the psychological effects, are pronounced. On persons with psychiatric disabilities, they're even more pronounced. And Jeff Metzner in Colorado has written extensively about this. And understand as well that individuals can be put in ADSEG for administrative reasons. So there are no established criteria. Every facility can decide under what circumstances someone would be put in administrative segregation. And when we think about the population that we serve, individuals with externalizing behaviors, where if they have frustrations, their mood is a bit more labile, they're a bit more expressive, that can be viewed as disruptive behavior within the correctional facility. And this is an individual who's being held down, a face shield put on to prevent from spitting, smock put on because they've already stripped the person, and being pepper sprayed while restrained by 4 individuals. It's hard to think of a situation in which that person's going to pose that much of a threat with the number of individuals around. What Jeff Metzner has also found is that once a person with psychiatric disability goes into administrative segregation, it's really hard then to get out because you have decreased sensory stimuli, limited access to mental health professionals to check on you, and so it really then becomes a bit of an abyss into which persons with psychiatric disability are placed. There are significant reforms that are happening, though. But I paint a bleak picture. There is hope. There's the restorative justice model, which represents a significant shift. This basically says that in the old model, the offender and society are the ones who are involved in this exchange. The restorative justice model says no, the victim and the offender has a duty to be accountable to the victim in certain ways, that the community has a duty to the victim to help maintain peace and restore order, and that bidirectionally, both the individual who's the offender and the community both have a duty to one another to ensure that that person's needs are met to prevent recidivism. And so very quickly, some of this involves programs that help individuals to take an inventory and general accountability for their actions, to understand where the origins of their criminogenic behavior reside. Changes within jail structures to have special management units specifically for persons with psychiatric disabilities, and then specially designed treatment facilities in prisons where a person will be transferred to a facility that looks much more like a state hospital than it does a prison. And then lastly, and probably my strongest pitch would be that we really need to work on both sides of this problem, that community and state offices of behavioral health and departments of correction need to view this as a shared responsibility, that the population that we're talking about will interface with both. 95% of people who are incarcerated will eventually return to the community, and so improving ways in which information can be shared, there can be some continuity of care, that formularies can be uniform across the system so that people's meds don't get changed repeatedly as they go in and out of jail systems, as well as offender reentry programs where community mental health providers are incentivized to go and provide in-reach to prisons to prepare individuals, both those with and without psychiatric disabilities, for successful reentry into the community. Last point that in looking at studies on whether ACT level services, case management services, or no services had any bearing on whether someone would criminally recidivate after release from jail, what they found, not surprisingly, was ACT services had the best response. Case management less so, and not that different from no services at all, because the case management model was only designed to monitor. And what individuals who are leaving the criminal justice system need is not only those services that are reimbursed through Medicaid under Affordable Care Act expansion, but also those softer services of stable housing, stable employment, those economic securities that we all depend on to reduce stress and frustration in our lives, reduce risk of substance use, reduce risk of psychiatric decompensation. That's it. Sorry, I went over, I think.
So we have time for just one or two questions. Mark, do you want to start?
Again, thanks to the panel. And Patrick, I hope that in the future you'll learn to talk faster. That would work.
I felt pressured.
I hope it wasn't as bad as your nightmare. But again, thanks to the panel and to you, Madeline, for putting together such an extra panel. I thought there's a point to be made, which is that frequently when we think about a public health approach, we forget the treatment option. And we think, my goodness, we have to just focus on prevention, and treatment is not part of our package. But treatment of mental health problems is part of prevention of violence.
Yeah.
And looking at violence, whether